all the panelists and the speakers to come and occupy the podium. Dr. Arulmari Varman, Dr. Minu Mathan, and Professor Dr. Vanati.
Excuse me.
Due to there's a small change in the order of the presentation because Dr. Minu Mathan has to take an early flight. I request Dr. Minu to start the first topic, which is modulating your surgical techniques for the benefit of multifocal IOLs. Yes.
5 minutes for people to come. Otherwise people will miss. But we're going to start talking, introduce this course. Start talking, introduce the course, overview and all this.
So this course is titled as Mastering Multifocals, a Case-Based Approach. This VAST-based course with case scenarios approach inviting a panel discussions or the problem faced in adopting a multifocal premium IOL in a practice. We would also be touching upon the basics of biometry and how you would change your biometry techniques to attain an accuracy in these multifocal IOLs. We'll be talking on the latest in multifocal practice, the extended depth of IOLs, and we'll also give you on how the chromatic aberrating correcting abilities of the EDOF IOLs and with on. I want an audio feed also.
As we are waiting for the session actual time to start, 12 o'clock, just because we are all sitting here, we'll just start talking. Multifocal IOLs. See, I'll first go into surgical techniques, but then we should know that we have to select a patient. The patient has to have a drive. He or she should want to have a multifocal. And then we should evaluate properly, exclude people who are not fit to be taken. That will all be covered, and then start off with the surgical technique. Surgical technique is no different. It's just like a cataract surgery. So any cataract surgery, but the pressure is on because most of these multifocal IOLs come as single piece IOLs. So it's very, very difficult to implant it if you have a PC rent or even if you have a Rexis. So there are multi-piece IOLs which AMO makes, but then no financial interest in this. But most probably you will be having only one lens, and then you will be under little pressure to have that implanted into the capsular bag. So just like any other case, you can be free, but remember on the back of your mind that there is something which we have promised in its premium and you are charging more, and patient has a lot of expectations. You have counseled so much, told so many wonderful things about the lens, and then finally if you are not able to implant, it will be a great disappointment and patient will be very, very unhappy. And you will also feel very bad. So, be very careful. See, I don't say, most of my talks, I don't say this step we have to do carefully, that step we have to do carefully. Everything we have to do carefully only. But only thing is, we have to keep in mind that we may need to slow down a little bit, take some more time. And another point is to make the patient feel more comfortable. See, some patients may be quite elderly people. They would be coming in with their children. They want these people to have convenience of multifocal IOLs. They want to read and do their daily activity without glasses. So we are providing them with the possible alternative, which is whatever is available right now as multifocal IOLs. But then some of them may be really old. They may not be able to focus onto the light and keep steady and all those. So during a procedure, we should not make them feel that it is a difficult procedure, they are not cooperating, there is something wrong with their attitude or their behavior during surgery. Then they will feel sorry, and they will also feel that something was not done right, it was paining, and they will attribute all these things to some kind of little dissatisfaction which they may have later on. So during the surgical, the whole procedure of surgery from the time they come into the hospital, they have to be treated little differently and a little better than other people, so that they feel that they are premium people and they are taken care little more. And so if they are happy with all the if they are happy with all the activities going on around them, making them feel good, then they will forget some small things which happen post-op, some irritation, some kind of reading difficulty and all those. So to make them happy is another important thing. I think there will be a talk regarding unhappy patients, dealing with unhappy patients, but then surgically, when they come, somebody receiving them, somebody not standing along with the other crowd, taking them to a separate room, making them wait, not to make them wait too much, and tell them that you have to dilate, it may take some time, and take them into your procedure, either topical or block. Block means, I think either you or an anesthetist has to talk for some time and make it as painless as possible. See, nowadays it is very easy to give very slowly and gently retrobulbar or peribulbar. Retrobulbar we don't give. Peribulbar or subtenons without pain, no pain at all. So that is one way you can make them very comfortable. And bandage them and tell them to take rest, or they will be okay with that. Rather than insisting that you will do only on topical. There is no point in insisting that you will be doing only on topical. Okay, so now 12 o'clock. Start on no financial interest in this presentation. So this is one video I have recorded some time back. So we will go step by step. Once we have selected, patient is on the table. So topical. So from the beginning, see the first point when you are sticking a drape and putting a speculum, this itself can intimidate a patient. So this itself can be painful. So try to choose a speculum which is not very hard, very broad, and see the size of the eye and the socket, and choose one which does not require too much pressure to apply on, and they should not feel this one going inside. So once this is in, then I start off with lesser illumination. I bring it down to 25% so that anybody can look at that light. So even with cataract, they will be able to look at light a little better, even if it is very high. But then still I bring it, you don't need this 100% or 75% light for putting on the drape or washing the eye, cul-de-sac and all those. So then you can tell them very gently that there is light there, please look at the right. See, one thing is you have to go under the microscope, your own microscope once, and see what you see under the microscope. Rather than telling them look at light, they will look at the light, tube light which is there somewhere there. So look at the light, how many bulbs are there, what reflex you see, color, shape and all those, and tell them accordingly. So then they will look at it. And now washing. Again, this is a very bad experience. If you feel yourself being flushed with saline, which is a little cold, initially it feels little odd. You know, a vasovagal kind of feel you will get. So start with drops onto the cornea. Cornea and anesthetizes better. So cornea you start with start it as drops and then make it a gentle stream and then go along to the periphery and all. So here patient is nicely cooperating, staying put. So while injecting itself, while spraying with saline itself, they will squeeze. Some people will tend to squeeze. So then make sure you put one more drop of paracaine and wait for some time. Paracaine or lignocaine and not waiting at all doesn't work. So to take 10-15 seconds, wait, stop, and then continue. Come, Arvind. So, and then my policy is not to touch conjunctiva at all. So no touching conjunctiva. Paracentesis, everything choose very sharp ones and things which you are used to. Don't take anything special or something which you have not used to because this is a premium case. So things which are used to, and then I make a paracentesis enough for the second instrument to go in, because titrate your incision so that there's not too much of leak through that. It can affect your surgery, and also you can fluid keeps on flowing outside the eye and it irrigates over the eye and makes the patient feel little messy. And then the incision as good as possible, same thing what you do, a biplanar or a triplanar one with very sharp instruments. And then again, this is 1% preservative free lignocaine, little bit into the eye and wait for some time. And then again, no intermittent splashing of saline. So you cover up the cornea with visco and then replace visco rather than putting in splashing saline all the while. And then I use viscoelastic HPMC first. So here, see, this is some pupillary membrane which is there. I'm releasing that. Nothing big deal about it. But then having a rhexis, very important. Centering a rhexis. So the IOL later on gets centered angle alpha, I think they'll all describe on angle alpha, angle kappa and all those. So finally we'll show you how to center, but then rather than making a larger rexus, I would go in for a smaller rexus or an ideal sized 5.5 rexus. But 5.5 I cannot always make a ideal sized round rexus. So either you mark or whatever you are used to, do the same way. Don't do anything special for this, but then make it slightly smaller if possible rather than being larger, because you need a full overlap of the rexus with your same instrument, same technique. Once that is done, hydrodissection. Again, this is especially in myopes and all. Hydrodissection gives a little pressure on the ciliary body. Again, they feel some pain. So you tell them that there may be some pressure feeling. And also, just now when you saw, I had debulked the anterior chamber by pressing down. So it takes out the anterior capsule and also it reduces the pressure inside the anterior chamber. Now comes the most crucial thing. This is viscoat. So I include that in the package of this multifocal patients and then use liberally viscoat. So once you have hydrodissected, a lot of HPMC has gone out. Now you put in viscoat. You want this to cover because clear cornea, getting clear cornea immediately and first day post-op is very important. Otherwise, again, they'll struggle. See, already they'll have to struggle a little bit post-op to get used to the multifocality. So the cornea should not be hazy. So here again, putting the viscoat just under the endothelium. You don't want it to be in the rexus area. And then again, to press it up onto the endothelium, I put HPMC just onto the surface of the lens. And now technique will be the same. I take a little time extra to do it little more carefully so that I don't create a rexus tear or a PC rent. And then technique is same. Divide it well and let not the pupil come down too much. So then movements should not be too irregular inside. The current should not be too bad. So here it is finished well. And the cortex aspiration. Again here I put in HPMC first to fill up the bag and then do cortex aspiration so that you don't immediately catch the PC if the bag is empty. And then I go subincisional in the beginning itself because that is the time when the bag is full, and then you can aspirate the cortex very well. So again, cortical aspiration and trying to prevent PCO is very, very crucial. So here you can see that there are cortical fibers which are sticking onto the capsule and it needs polishing. Either you can use the cap vac mode or you can use a manual method, or you can use your saline jet to irrigate on the capsule. And underneath the anterior capsule, it's debatable, but then if at any point of time you want to explant this IOL, if you aspirate all the lens epithelial cells from underneath your rexus margin, then it won't fibrose that very hard. So it is easier to explant these kind of IOLs if you do that, but if you're selected well and if you do well, most of them should work well. So here I'm doing the hydrojet irrigation. So especially from the visual axis, it should completely go because minimal PCOs can affect the multifocality, and also from inside the bag also, equator also. So multiple directions. If you are used to bimanual is also good. I'm basically using. So here again, going in with sodium hyaluronate. So after irrigation aspiration, I don't put HPMC or even viscoat because it's very difficult to remove completely. So this fills up the bag, forms the space well, and then it can be removed completely and more easily. So once that is done, you take the IOL. See, very important. Use an instrument which you have to check the inner surface of your instrument. It should not be it should be ragged, it should not be having serrations, and it should not create any mark on the IOL. And don't hold on to too much into the optic like what I am doing right now. Don't do that. Catch at the haptic optic junction alone or even the haptic alone. So, and load it as you load in your one, but keep it somewhere near. So suddenly sometimes you may drop the IOL, and if you drop the IOL and that's it. So keep it in a sterile area so that even if you drop it or do something, it can be retrieved. So injection is the same. Go gently. Make sure that your injector tip, see here this one, this tip should not be overriding on the IOL. Then suddenly it may go in with a jerk. So look at your injector. It may be reused multiple times. The tip might have become straighter. So it should have a little bend so that it will push the optic alone. And it can go into the bag partially. Later on you can dial it in, whichever way you're comfortable, the same way you do in regular cases. Now once it is in the bag, now you look at the overlap of the rexus. Because I have done in this case as a smaller rexus, you can always extend it at the end of surgery. I have seen Dr. David Chang doing most of his cases like this. He does it smaller, and then after implanting the IOL, he extends it to appropriate size to have good overlap, because this is very important for centration and for preventing PCO later on. So especially, so if it is covering all the areas except one area, just it has gone out of the rexus, the optic, then again it can cause fibrosis and it can extend from that side. So please make sure that you don't make a very large rexus, and after that aspirating the visco behind the lens also. So I just lift it up. You don't have to move this much because this lens is loaded in HPMC, so you may have to go aspirate under the optic also. And this sodium hyaluronate comes out very easily. And once that is done, then now I make sure that these two Purkinje images overlap. So this is, and that is within the central ring. And if it doesn't overlap, and if you want to nudge it a little bit, angle kappa and all those, nudge it a little bit in the bag, 5 degrees and all, small push will help you to align it properly and keep it pressed for some time, 5-10 seconds, so that it remains in position. And these are lenses which will remain in position. And once that is done, I always put in our Vigamox or your moxifloxacin intracameral, and then close the incision and make sure that the patient is very comfortable. So that is this is the way you finish. Only one more, this is a short one, but I would say small pupils if you take, I usually don't tend to use iris hooks if possible. See, we don't want to damage the sphincter too much, and you want the pupil to be nice and acting. So if possible, continue with your mid-dilated pupil, but if it is too small, definitely use stretching devices, but don't stretch it very, very much till the limbus don't stretch. Stretch it up to 5 millimeters so that you can have a 4.5 or a 5 millimeter rexus, and then continue, because at the end, but at any point of time, if you catch the pupil, or if it comes down further, don't hesitate to put in iris hooks, because you have to finish the case well, and it has to go into the bag. The pupil comes secondary. The rexus has to be complete, and this is again your multifocal going inside. And if it is a small pupil, you have to make sure that it has gone into the bag, and you can always center it by matching the Purkinje images. Post-op, I think they will deal with the post-op management, and it's regular, like in any patient, especially you add sodium, the NSAID which you add, I add for all cases, and you give the same thing for, and use more of tears, because tear stability, tear film is very, very crucial for the good multifocality and the good post-op outcome. Thank you very much.
Thank you, Dr. Menu, for this excellent talk. As all of you know, Dr. Menu has won a lot of awards on cataract surgery in various conferences. A few questions before you leave, Dr. Menu Martin. Do you do you do any special techniques to center the rexus whenever you started? Because you know the centration of a multifocal eye is very crucial. Do you just go ahead and do your rexus, or you take any special steps to center that?
As I told you, it's very always, I do not get a very central rexus in all my cases, but then I make sure that the patient looks straight at the light, and I follow that light reflex. Following the pupillary margin may not be always right. Sometimes pupil dilates more in one side and less in one side. But I make this the central reflex. Some people mark on the cornea, some people use markers. It's all according to how you are comfortable doing a rexus. I usually do a rexus which is okay size and okay centered, but I don't take special thing, but it has to be centered. So do centered rexus in all your cases, and in this case also you will center it well.
Dr. Harowins to get his slides ready. He's going to talk on the basics of multifocality, the diffractive IOLs, which have been in practice for a very long time, and also a short note on how to select your patients pre- and post-operative counseling.
I'm sorry that I have to leave because of an early flight, sorry. If anybody has a question to clear, we can do it, finish off now.
Presentation.
That was a wonderful presentation, Dr. Menu. Just a question, we all know that we do need an intact rexus for a multifocal IOL, but in the event you have a small rexus rupture, is there anything would you like to advise for the rescue?
Yeah. Many of these single piece IOLs, if the rexus margin, for example, if it's at a turn in inferior 6 o'clock, so you place your haptics oriented hitting the equator at 3 o'clock and 9 o'clock, and take out all the viscoelastic, it usually stays in place. The one rexus tear just remains open like that. You will get PCO, but that is different. But the centration part usually doesn't create a problem. So you can place an IOL if the rexus is otherwise intact. You can place it inside the capsular bag, aspirate all the cortex and then press down for some time, 10-15 seconds. Press the lens onto the posterior capsule while your irrigation is on, and then it should stay. So it's not a really contraindication to leave.
Hello. Can we measure angle alpha with IOL Master 500?
Angle alpha is in LensStar you can measure. In LensStar you can measure, but I'm not sure, it's not there in IOL Master. But LensStar you can measure, and angle Kappa with your eye trace and your Synopter also. We had, sir, do you think you can measure angle alpha with this one? LensStar gives, that's for sure.
IOL Master 700 gives.
700 gives.
And of course, the eye trace will give you alpha and kappa.
Yeah, alpha eye trace wins me. So, but then this one LensStar will give 700 should give.
Okay, if you have no more questions, we'll move on to the next topic. Dr. Arvind, to you.
The multifocal IOL started with the earliest of lenses. So going back, the IOL surgery started with Harold Ridley putting in a PMMA lens into the eye. There has been advancement from there on. So the need for multifocal IOL is nothing new, because whenever we replace a lens inside the eye, we all need to become normal. That means that we want to see distance, we want to read, we want to do everything normally as we would do otherwise without the glasses. So it started in the early 1980s. Then based on the principle of refraction of light, people started making lenses that can bend lights like a bifocal lens. One zone of the lens focuses for the distance, the other zone focuses for the near. So that's how the refractive lens came into being. The refractive lens being made up of different zones. Some of the lenses with focus for distance at the center, and the others have focused near vision at the center. So there has been much improvement from there on. I don't want to go into the details of the refractive lenses because they are now more in use. Now then came the diffractive material. So what happens is when the light goes through a small aperture, the edges of the aperture turns the light from one side to another. So that's the process of diffraction. So if we can cause positive interference of these light that is getting refracted at different planes, it forms a focal point. So it forms different focal points. That's how multifocal came into being. So when you talk about, say, multifocal, actually it is a misnomer. It's multifocal for the lens perspective because it is causing multiple focal points, but only two focal points that are actually good for seeing. So actually basically normal multifocals which we discussed are actually bifocal lenses. So when you look at the different types of things which are available, the diffractive and the refractive things, the diffraction causes two clear points of focus than the refraction. The reason being is the refraction causes the prismatic effect. The prismatic effect of the lens also increases towards the periphery. So it forms multiple focal points than the diffraction process alone. So what happens in the multifocal? It has its own advantages. It gives both distance vision. It can give you good reading vision. As I told you, the refractive multifocal doesn't give very good reading vision, or if something that gives you good reading vision, they have problem with distance vision. So all the lenses enhance the depth of focus of the patient. So when you look at the multifocal, as I told you earlier, it is indeed a multifocal. If you look at this image where different rays forming different points, but actually from the patient perspective, so far these multifocals have mainly been bifocal lenses. Now they are called trifocal lenses and so on. So the different types of multifocal IOLs in the market ranges from the old technology of rezoom to current technologies of diffractive, refractive lenses of Technis, Restore, Acrylisa and IDIF and so on, some of the Indian manufacturers also. So what are the expectations in a multifocal? When you look at the multifocal, what we want is a full range of vision. We need the accuracy. That means that you want to see distance clear and then you want to see reading. You have to be very certain. We don't want a lot of photopic effects. That means that glare, halos and things like that. And optimal use of incident light. The reason being is there is always a loss of light. As I have shown that previous slides, multiple focal points are formed. So in both the distance and the near foci, not all the lights are formed. There is about 15 to 30% loss of light on different lenses, and good lenses have around 15% light loss. So only 85% of contrast remains. In the 85%, some of the lenses uses 50 for distance and 35 for near. So that's what happens. So these are all the different ranges in which it is available, and as you know, all the multifocals are available in 0.5 ranges. The key to success is patient exclusion, I would say. Which patient you don't want to do is very, very important. Then the patient counseling, training of paramedical staff, and again the IOL power calculation, which has to be very precise. These are some of the differences between refractive and diffractive multifocal lenses. The most important being is the pupil dependency. In case of diffractive lenses, they were little bit pupil independent, and you can also have some decentration of lenses which is tolerated to a large extent in these type of lenses. The most important thing is conclusion of this current multifocal technology. There has been a lot of improvements. All current day new generation IOLs have become more affordable for the patients, and they all give good clarity of distance and near vision. And now it comes to our choice whether we want to use it. But still I would say, just watch this video. Back. Yeah, just go. Yeah, it is in the computer. No, I will see. Switch on the sound. Switch on the sound.
Charlie bit me.
So this is one of the videos, like Charlie is very nice with his brother. So they were playing together. Multifocal is just like that. You can play with it, but you have to be very careful. Choose the right patient.
Ouch! Ouch! Ouch, Charlie! Ow! Charlie, that really hurts.
So it is like that. So what's that?
No, Charlie bit me. And that really hurt, Charlie, and it's still hurting.
Okay, but anyway, like Charlie, the multifocal lenses can also affect. So the most important is the two key issues in patient selection. Patient lifestyle needs and expectation, details of patient work, leisure activities. Each multifocal has its own strength and limitations. So rather than, you do a lens and then patient is not happy and then he wants to call you in to eat you. So each time he comes, he is going to take away a lot of your time. So there are very, very important things which we need to go in. The positive characteristics of a patient is, they should be easygoing, hyperopic patients rather than myopic patients. I'll go into that little later. Hyperopic, they should be presbyopic. They are very happy about that. Having bilateral cataract is very helpful. The reason being is you do one eye and they are even 612 or 69. They are very happy because the other eye they are only 624. So they can see that I am able to see better with this eye. So unilateral traumatic cataract in otherwise normal zonules and pupil. The predictors of an unhappy patient are not so motivated to be glass independent. Like he doesn't mind wearing glasses. He doesn't tell you that I don't want to use glasses. Don't push multifocal lenses on the person. Somebody who is unwilling to adjust, even if he comes to your practice, he says AC is not working, AC is not very cool and things like that. The moment you hear those words like you be careful, they are not good for multifocal patients. And also demanding patient who wants perfect vision. Will I get 6/6 and 6? Sir, you are not a good candidate for surgery. This is about, multifocal is about good vision, good quality of vision, good independence from glasses. Any patient with unstable capsular support, be very, very careful. Predictors of an unhappy patient: significant dry eye, corneal scarring, mild to moderate myopia, somebody up to -2 diopters. They are seeing excellently well with the reading without the reading glasses all this time. Be very, very careful. And then pupil size, which is very small and very big. You have to be very careful. And the third thing is monofocal implant in the first eye. We have to be very careful if the monofocal implant is in the non-dominant eye. If it is in the dominant eye, it is fine. I will show you how to check it. Uncorrected post-operative astigmatism, if you are going to leave more than 0.5, be careful. Monovision, which is very important thing. For monovision, you have to know like which eye is the dominant eye. When you know the dominant eye, you can use micro monovision. You can consider mix and match to give them a good quality of vision. No, sir, I will play it. Please leave me alone. No, please leave me. So this is a small video on how to check
Your arms up with the hole
monovision.
focused on the camera.
So if you look at
through
it,
the hole, then close off.
you can just ask the patient to form this triangular thing and then look at you. And then if you look at them, they will actually see through the dominant eye. The eye which you are seeing is the dominant eye. If you ask them to close that eye, you will find that patient's eye is closed. So like they make a finger like that and then you look through that, you look at the dominant eye. You ask them to close that one eye and then you will see that eye being closed, that's the dominant eye. This is very, very important thing. In the dominant eye, it is better you have a good clarity distance vision. That's why I'm saying if you have a monofocal lens in the dominant eye and they are seeing clearly 6/6, very happy patient, you can do a multifocal in the non-dominant eye. If you are seeing a patient who has a 6/6 vision in the non-dominant eye and then you are putting a multifocal lens in the dominant eye, be careful because they will expect very good clarity distance for vision which we may not be able to give compared to that of a multifocal patient. So the desired post-operative refraction while you are planning is the post-operative result to be exactly 0 or just about plus 0.25 for distance. Because most of these multifocal lenses have a +4 diopters near vision. So that means that 25 centimeters and we don't read at 25 centimeters. And then if you err by -0.5 in those patients, you are going to bring that much closer to 20 centimeters and no patient is going to read at 20 centimeters. So you can err on the hyperopic side, have about +0.5, so it helps them aid in distance vision, and you even err plus 0.75, still they are able to read very well at 35 centimeters, which is the normal reading distance. So you target the first eye. If you do the dominant eye, you do very well, little hyperopic. Patient is not very happy with the refraction for reading. You can always give a little bit of a minus or 0 in the other eye, so they can have a better clarity of vision. Keratometry is very important thing to see two things. As I told you, irregular cornea is not good for multifocal lenses. So one thing is you can consider the astigmatism, think about doing incision on the steep axis when you do the surgery, do LRIs for this patient, or consider a toric multifocal lens for this patient. Axial length, you do both eyes. Whenever you are doing a multifocal patient, please always do axial length measurement for both eyes. Make sure the axial length is within 0.3 millimeters or 0.15 inter-eye difference is very less. The reason being is you correlate with their pre-operative refraction also, old glasses also before they developed any nuclear cataract, to see if the refraction between two eye matches with the axial length what you have measured. This is very, very important. So controlling the astigmatism, again as I told you, don't leave anything more than 0.75 in a multifocal patient. They will be very, very unhappy. There is no room for error in these patients. You know, the reason being is like this funny video. It is very easy to say, okay, he has committed a mistake. There is nothing we can do like that. He is a very lucky fellow who has a very smart colleague working with him. so you have done a good surgery. This cannot happen. The reason being is there is nothing you can do because the patient is seeing with his own eyes, seeing your face sitting in front of you. So conclusion, minimal errors from post-operative target refraction, maintain high level of patient and surgeon satisfaction, achieved by excellent biometry. And then one important thing which I need to tell you is you don't have a good optical biometer, don't worry. What works, what formula works best for you in each and every case of your practice is the one you have to depend on. There are some people who send a multifocal patient for optical biometry. Don't do that. You do your own biometry as you would do normally and do the surgery, because you know what you will get with the lenses for your measurement with your biometer. If you send it for something else, it can give you a different value which may be wrong for that patient. So this is another very important tip which I want to tell you, though Minu has spoken about that. I have a small tip here, in centering the lens. So when you implant the lens, so you clear the bag as Minu told, like nicely, don't leave anything in the bag. The rexis is very nice and centered. Actually, I implant the lens under irrigation. I use bimanual irrigation. You can see that I am not putting any viscoelastic during the irrigation. And then once you dial it, clear little bit of viscoelastic, whatever that is there on the lens, and then you keep it very much centered. So as he said, you can look at the Purkinje image and center it, but only tip which I add what to Minu has told is, you cannot push the lens and nudge the lens inside the bag. Remember that. Even if you little bit nudge the lens inside the bag, it will again come back to the same position. If you want to change the centration of the lens, what you can try is keep rotating the lens. The bag is not the same circular bag everywhere. The bag is different in different meridians. So if you can slightly dial the lens, you can move the center of lens by 1 millimeter nasally, superiorly, temporally. So you keep dialing the lens till you get into a place where the Purkinje images, the light reflection from the corneal apex coincides with the, the reflection from the eyeball. You can see here. So if it is not in the center, just dial the lens. You cannot just push the lens by 0.5 millimeter and leave it there. After some time, it's going to come back to the same position if you fill the anterior chamber. So that's one thing which I wanted to give you. So the success of multifocal implant is as such. The post-operative things are very important. There is something called physical management. There is some patient counseling post-operatively, which I find is very important. So it takes about 60 to 120 days for adjustment. But most importantly, when the patient comes, rather than taking a refraction, you first look at the eye and say, oh, your eye looks very great. So that's very important. You have to give them the wow effect. The wow effect comes from the doctor. Nobody else can give that wow effect. Look at the eye. Oh, fine, fantastic. The lens is very well centered. Everything looks great for you. How do you feel? Don't even check the refraction. If the patient says, I am happy, I am seeing well, did you read? Don't give them the reading chart and ask them to read. Take their cell phone, give it to them. You see now, because the font is N8 or better. That's what they are going to see. Why do you disappoint them giving the N6, N5 number and say you read? You give their cell phone, see the contact. Yeah, I'm saying my wife has called that last number. Oh, I didn't see. Why you didn't see yesterday? No, I didn't see because no, after surgery I should not see light, I should not read. No, this is a beautiful lens, this is a beautiful surgery. You can see from next day. You can read now. Yeah, I am reading it. You can see your WhatsApp. He sees WhatsApp. See some nice photos. His son has sent his selfies. Oh, he is very happy. The wow effect is created. Everywhere it is, don't give it N5 chart reading cataract spoils vision. Okay. What is there he is going to read in that you have cataract? If your vision is bad, you have cataract in the eye. He is not able to read that line. He will ask you what it is written here. If you have a cataract in your eye, you don't read. Have you not removed all the cataract in your eye? He will ask you. Why do you want to show that? So this is what they want. What multifocal is about? Normal vision. And then the other post-operative counseling is, as I told you, these lenses work from 25 centimeters to 33 centimeters depending on what they want. So you teach them where to read. If he puts his cell phone, he is not able to read, you bring his cell phone forward and backward. At some point, he will see it clear. Tell him, this is the reading distance for you. Whenever you use the cell phone, you use it at the distance. Slowly it will get memorized in your brain. You won't worry about it, but for 2 days you have to adjust that. That makes him feel like that is good. Or otherwise he will keep his cell phone here. He is already a presbyopic patient. He has been always reading here. Your multifocal is not going to work at this distance, only at this distance. So if you teach him where to read, he will read very well at that distance and then be happy. This is the most important post-operative counseling you need to do. You can check his vision at 1 week post-op, that too after doing a AR also, just to make sure that everything is fine. Okay? Ghosting, another concern, you have to tell them. When the first day itself, when they come, he is happy, the wow effect is there. That time you again put him on the mind. You might see some little round yellows around the light. You might see 1 or 2 days later while driving, you might see. You just ignore it. I tell them one important thing, okay, which you can use. All cameras have 12 megapixel cameras. All cell phones have. Is the photo in Apple iPhone with 12 megapixel is the same as the Oppo 6000? The patient will answer no. Why? It is because the brain that processes it. Similarly, your brain processes the image what you see. You might have glare and halos. At some point of time, it will remove the glare and halos. So if you allow it to remove it, it will process. Then he will think my brain has to be iPhone-like. He is top class. No, nobody wants to say his brain is bad. So he will say, okay, I will adjust it. I will wait and see. Very important things, psychological. So patient education and counseling is very important. So conclusion. First, post-multifocal IOL surgery is very important for patient and surgeon. Give the wow effect by yourself. See with a smiling face. Wow, so nice surgery. Look at your assistant standing near you. Most beautiful surgery I have done ever. For every surgery we will tell like that. So the key to managing this is vital period is good post-operative education and post-operative management. Now we will concise it. 10 managements. This is very, very important, you know. Mother of all rules. Rule number 1, not sure if you want. Don't force multifocal on your patient. Okay, you explain to them, then he has to ask you, can I have a multifocal? Can I have reading and distance vision? Don't force yourself on the patient. That is rule number 1. Rule number 2, before you meet the patient, first convince yourself about the multifocal technology. Today somebody came to your Zeiss, came to you, said multifocal ours is the best. Tomorrow somebody comes, Restore is the best. Tomorrow somebody comes, Technis is the best. Don't meet the patient today, I want to do a Technis multifocal for this patient. No. Let them come in, you talk to them what their job is. Are they driving, you use an extended vision lens. Are they computer, you use a less ad. Is a lady who wants to read, you use a +4 ad, a lens with a +4 ad, so she will read very well the shloka books and say Ram, Ram, Ram. Oh, Ram will come and bless you. He will say that when they come and see you again. It's very, very important. Don't decide the lens before you talk to the patient. Better have the K value handy. The reason is whenever a cataract patient comes, I always ask them to mention the K values there. When you see the patient, you tell multifocal and the lady has a +2 diopter astigmatism. Then you have to consider changing over to toric multifocal, again the package changes. So if somebody has a very irregular astigmatism, have the K value handy before even talking to the patient, selecting the lenses for them. One wrong choice, be assured you will be like, hell, like Charlie will bite you and you will never do a multifocal again. Define reasonable expectation. The reasonable expectation is I don't tell them 6/6 N6. If I am going to do a multifocal, forget 6/6 N6. You have to think about, okay, I am going to see distance, I am going to see near, I am going to do everything what I am doing today without glasses. That's the thing I am going to do. Don't come into my office and say I am not reading this number, that number. Are you able to see TV? Are you able to watch your cell phone? Are you able to newspaper? That's what I am going to give you. And also you tell them, multifocal creates some disturbance and it gets cleared over a period of time. If the patient is going to ask you, what the disturbance like? How am I going to get it? 100% will it go away? That patient, 100% you go away to go and have a multifocal done. Okay, so that's one thing. And the patient has to be cool as ice and you have to be cool as ice. When they ask question, you have to answer and the patient also thinks and gets all the answers from you and be cool. Rule number 3, demography. Very, very important choice. Female, above 60 years, TV addict, not a bookworm, great. The reason being is you gave 6/9, 6/12 vision, Shloka book N10 or more, she is able to read, not reading very much. They are very, very happy. They are not going to drive. They are not going to expect N6. What they need is good TV, good reading. I am happy with that. She is not going to read a newspaper. Don't worry about it. Rule number 4, character selection. If somebody is nosy, as I told you, AC is not working very well, your staff is not well dressed, she has not put in a lipstick, no way, that patient is not good. Fussy, perfectionist, cribs, borderline personality who asks hundreds of questions, no way. Rule number 5, individual lifestyle, that's what I told you. Is computer work or reading, you have to remember. Vocation, if you have a jeweler who wants to see near, don't give him a multifocal, please, because he wants to see the 10 centimeter, no multifocal will give him 10 centimeter. He needs pristine vision, he looks into diamonds to see for flaws with a magnifying glass. You cannot give him a multifocal and say, oh, you will see well. He is not a good candidate for multifocal. Just give him a monofocal lens and ask him to use his lenses, because he doesn't need anything for reading. His near work is looking at diamonds and jewelry, which is a 10 centimeter monoocular using a magnifying glass. He doesn't need a multifocal. His profession doesn't need a multifocal lens. Motivation or determination. Somebody says, I have never worn glasses. He is +2 for distance and he is +5 for near. Never use glasses. Well and good, very well, baby. You are the best patient for my surgery, because he will be very happy with 612 vision and N12, because he was N60 before surgery and he was 636 before surgery. Never use glasses. He will definitely feel better. Then the spectacle rule. This is what I am saying. 1 to score. Never use glasses. He is best candidate. Tick. Number 1 candidate. Go away. Rarely for reading. He is also a good candidate. Occasionally for reading. Moderate. Often, not always. Okay, choice. Always, anytime. Don't think about multifocal for him, because he is very, very fussy. Even for -0.5 cylinder, he is using glasses. He will expect that kind of vision. Rule 7, visual acuity rule. Vision 6/6 plus response. I feel my vision is very blurred, but I am not reading the last 2 letters on the chart. That patient you are not supposed to do. My vision is 6/18. Can I wait for some more time? These are the patients you should do multifocal. Okay, rule number 8, cataract. PSC patients tolerate multifocal better because they are used to glares and halos and whatnot. Even before surgery, they had the worst nightmare driving vision. When you put in the multifocal, it gives a lesser nightmare than what they had before, so they will be happy. PSC is very good. Nuclear cataract with little myopia, beware. They had good distance vision, they had good reading vision, they were very happy till the time you forced a surgery on them. Cataract in both eyes, again excellent, because the other eye vision is so bad, they will think this eye is very good, I am able to read, I am going to see near, and they will come for the other eye surgery. Rule 9, which eye to choose from? I always choose the better seeing eye first whenever possible. If both eye has cataract, do the better seeing eye first, because the worst seeing eye is always there for you. In the deferred surgeries, do the non-dominant eye first. This is very, very important. In a deferred surgery, non-dominant eye first, because the dominant eye is good for distance. You are giving them reading in one eye, they will be very happy to carry on till the time they come back to you for other surgery. If you put in a multifocal on a dominant eye, they will come and kill you. In myopes, go for the eye with higher myopia first. The reason being is they are used to very bad distance vision in that eye. Post-cataract surgery, they are having better distance vision than before surgery, they are very happy. In hyperope, this is opposite. Go for the eye which has least hyperopia and target emmetropia. They are very, very happy. They get very good distance vision. The other eye is having very poor distance vision and very poor reading vision. They will appreciate your multifocal better. Most important, don't go and fish for your multifocals. Like going inside the ocean and catch a fish, which is not possible. You have to sit yourself up tight, and then you have to catch them. They have to come and catch the feed. You cannot go and catch them. So counseling, it should be a controlled, sustained release. Don't tell all the positive in one time, all the negative in one time. Disadvantages and positivity should be mixed together. Glare should be mixed with the advantage of reading. Glare should be mixed with the advantages of, not using glasses when you are going out in an emergency. Rule number 10, the most important. If you can't convince them for a multifocal, at least don't confuse them. This lens, that lens, this 50,000, that is 70,000. They will run away from you. Most important, convenience. Multifocal is about convenience of distance and near vision. It is going to be never a perfect distance and near vision, at least in the near future, because even though our technology has improved so much, there is still lot of things to be improved. So the concept is you have to convince a patient versus convincing patient, you know. So the most important is you convince a patient, don't have a convincing patient, because he will convince you for all the things what you have done, you are responsible. So thank you very much.
Thank you, Dr. Aravind, for this extensive talk and an interesting talk and those practical tips. As all of us know, the multifocal technology has evolved from refractive and diffractive, and we find those lenses are having some problem and we keep on moving on. So now I invite Dr. Arulmozhi Varman, who's been a pioneer in multifocal practice for a long time, to talk us about trifocals, how we achieve success with these lenses. Dr. Aravind, a few questions to you. Do you really counsel all your multifocal yourself, or you leave it to a counselor?
The preliminary counseling and understanding a patient whether he is fit for multifocal is done by me. I don't leave the counselor to choose a patient for a multifocal. I identify the patient and I tell the counselor that this patient is good for multifocal also. So when they are talking to the patient, they will start with the multifocal because that is their preferred choice, and then the patient can make the decision.
So over to Dr. Arulmozhi Varman for his talks on trifocals.
Good afternoon. Thank you, Dr. Kumar, for inviting me to be a part of this nice IC. So my talk will be on fine-tuning for toric multifocals and toric trifocals also. So what do we need to do when you're addressing a corneal astigmatism that is pre-existing? First, you don't induce any more astigmatism, so your incision should be astigmatically neutral. Before that, you need to be sure that the quantum and the position of the astigmatism is accurately defined. Then you need to do a very accurate calculation. So every company that makes a toric lens has their own patented calculating software to give it to you. You could use that, but preferably use Barrett Suite, which includes the Baylor nomogram, or go on the net. You have the ASCRS software that lets you calculate toric lenses, which is far more accurate than the one that's given by the individual companies. Thus, do you need to have an optical biometer for one of these things? It's not really necessary. I really don't believe that the optical biometer gives you any great accuracy in the measurement of the length of the eye. Yes, it does give you a small amount, but that's the least. Where does the optical biometer score? The optical biometer is able to give you a better keratometry than what you would achieve by your manual keratometer or any other means. There's nothing wrong in using a manual keratometer, particularly the telekeratometry that's coming in the recent swept source OCT-based optical keratometers is extremely accurate, and that's where it scores over. And most important, the new optical biometers have all the new software, and they're all available in one platform, and your calculation suddenly becomes more accurate. So you could combine this by doing a meticulous manual keratometry, doing a good ultrasound biometry personally using the immersion technology, and then going on the net and choosing an optimum calculating software, using the correct software and get the good results. But instead of going through all that problem, if you can afford to get a SSOCT-based optical biometer, it's fantastic. Then spend some time fine-tuning the A constant. It's not always necessary. Most of these machines, the IOLs that come in the market would have a separate A constant for the ultrasound and one for the optical. So depending on what you're using, choose that A constant. Rarely you will have to fine-tune the A constant. It is not always there. I have fine-tuned it personally for the Zeiss lenses, which is different from what is given by the Zeiss company. And one model of the Appasamy lens also needs fine-tuning. Otherwise, most of them, what the company gives, holds good. Why toric? Because we need to achieve minimal astigmatism. The previous speaker spoke about achieving less than plus or minus 0.5, preferably within 0.25 spherical error. It also holds good for the cylindrical error. If you have a cylinder of more than 0.5 or 0.75, multifocality is lost. So either you do in low cylinders in LRI, or in higher cylinders above 0.75 or 1, put a toric IOL in to get the best results. And toric IOLs give you the best and more accurate correction, and the correction is stable over years, vis-a-vis an LRI could degrade over years. Why trifocal? So we now understood why we do need to put in a toric lens when you're trying to put on a multifocal. Why would you use a trifocal? This is the answer. The trifocal gives you intermediate vision also, which is wonderful. All the other lenses available are all diffractive. We have all given up the refractive platform, which was truly multifocal, and shifted to the diffractive platform for lesser photic phenomena. Once you have only a bifocal, you lose our intermediate vision. And today, most of us need intermediate vision for computer usage and cell phone usage. The trifocal is the one that gives you, in the defocus curve, an intermediate range of vision also. So when you compare it, where did this come from? Yeah, here it is. So you have this defocus curve. You'll find that the trifocal has almost a flat curve. That means there is no defocus from distance, intermediate to near, when you compare it with a typical bifocal where there is a drop at intermediate level. So this is the reason to choose the trifocal. One, to get clear vision over all distances, particularly distance, intermediate, and near. Another important thing is the trifocal brings down the photic phenomena. When you use a monofocal IOL, you lose approximately 5 to 6% of light. Every optical instrument will lose light. In a bifocal IOL or the typical diffractive IOL, you can lose somewhere between 18 to 14% of light. That means the contrast sensitivity drops. In a trifocal IOL, depending upon what definition you're looking at, the loss of light can be as low as 6%, that is very close to a monofocal, or some of the other published literature will show you 9 to 10%, which is still very good. Instead of losing almost 15 to 18% of light with a diffractive bifocal IOL, the light loss is much lesser. That's why you have less photic phenomena. EDOF lenses also give you a good result in the loss of light. Unfortunately, they fail in the fact they don't give you very crisp near vision. And that is why trifocal lenses are today the best solution for a patient needing total clear vision over all distances. Why does this occur? A trifocal lens has one more refracting surface, so it should cause actually more loss of light and more photic phenomena. That is because the second order of the intermediate focus, which is around 1.75, falls on the first order of the near focus, which is 3.5. You can read this up, and that is why you have less loss of light and less photic phenomena in trifocal lenses. It truly works. So you get, in trifocals, you get clear vision all distances, reduced photic phenomena, and less light loss. So we'll come to the surgical part. So if you need to make the incision temporally. It could be superior temporal, inferior temporal, depending upon a right-handed surgeon, left-handed surgeon, right eye of the patient or left eye. And the incision should be posterior limbal, and it should be long enough to have almost a square appearance. If you can have some kind of a indication or that helps you to center the rexus, it's very good. You don't need to always have this Callisto or Varion or Ora. You could just take a 6 mm marker and center it on the right reflex before you start on the cornea, press it down. You get that impression that will stay there for about a minute or two, and that can give you very good centration. So a centered rexus is very good. The surgery is as usual. You just go do a phaco, you do a straight chop, however you like to do the cataract surgery. So cleaning up the... Here again, if you have access, when you're doing a multifocal that is toric, and you need to get the positioning very perfect, having a heads-up display like this with a markerless system, the accuracy is immense. But remember certain points that if you're doing any toric lens, please remove the viscoelastic from behind the lens, and in the capsular bag should be completely empty. And then you focus. Also look at the Purkinje images. They should overlap so you don't have any parallax error. So then you're centered very well, your results are very good. So you need to wait long enough that the lens unfolds totally. You need to remove viscoelastic from the bag completely, let the lens center very well, then position it accurately. If you don't, I hope it's not the same video. Okay, of course, if you have the flax, it does make it far more accurate. You get a rhexis that is perfectly centered. You can choose to center the rhexis on the visual axis or on the capsular bag, that is the white to white. So since it does an OCT, it can actually delineate the capsular bag and center the rhexis perfectly in the capsular bag. Wherever you center the rhexis, the lens is going to center only in the capsular bag. So having the lens centered or the rhexis centered on the capsular bag helps you in the long run. So the surgery post-flax is very simple. It just occurs in a jiffy. You'll find here that the centration of the rhexis is brilliant. The lens that I'm using here is a trifocal from Zeiss. The first video was bifocal lens from AMO, now J&J. Plate optic lenses are less prone to post-operative rotation. They are more stable than a C-loop lens. Here again, I'm using the Calisto system. So after you remove the viscoelastic, position the lens, and then you can switch on the Calisto to confirm. So it gives you the alignment is perfect. One more video. I use a soft shell technique. It makes your rhexis more perfect. I use chondroitin sulfate, and under that, sodium hyaluronate. And you get a well deep chamber that does not collapse. So does it appear that if you want to have very good accuracy in placing a toric IOL, particularly if it's multifocal, do you need markerless system? Is that the message that I'm trying to get across? Actually, no. You can get as good accuracy without the markerless system. The markerless system makes your life a little easier and gives you extreme accuracy, agreed. So I'll show you a video where you can achieve that even without any markerless system. You can mark using a slit lamp, which is the most accurate marking that you can ever get. Place the patient on the slit lamp. You can place the slit vertical, then it passes through the Purkinje image of the cornea. You can put it horizontal or place it in the axis that you're going to place the lens. Here at 61, so the slit has been placed at 61. I've used a needle to make a scratch on the corneal epithelium. I don't mark anything now because I don't want any ink on the corneal surface that would smudge as the surgery goes on. Yes, I do use the markerless system to center my rhexis. It's not entirely necessary. End of surgery, sodium hyaluronate, because I prefer a viscoelastic that comes out easily. Now I take the marker and make a very thin, long mark that goes right into the pupillary area. You want the mark to be thin, not smudged, and come right into the pupillary area. Now this lens is an Apasami's multifocal, I think it's not a multifocal, maybe a monofocal toric lens. It's hydrophobic acrylic. Put it into the bag. Fortuitously, it comes and sits straight there, but I'm going to rotate the lens all around just to show you that the difference between rotation before and after removing the viscoelastic from behind the lens. The viscoelastic has not been removed from behind the lens rotates very easily. I'm able to rotate it quite well. Once I go back, now remove the viscoelastic, the rotation becomes difficult. So that's a take-home message. In all toric lenses, please remove the viscoelastic from behind the lens before you position it finally, so that the lens will not rotate in the immediate post-operative period. Most rotation occur in the first 2 to 6 hours when the bag swells up. The Purkinje images are not in sync. Don't align now. Get it aligned, and then with the Purkinje images in line, do the final alignment. It's aligned. Fine. So it looks good. Cross-check with the Calisto. Perfect. So I don't need the Calisto to get the same accuracy. If you can spend 5 minutes doing the marking personally on a slit lamp, you can get the same accuracy without a markerless system. Yes, if you have that, it's well and good. Check immediate post-op. Maybe an hour or two later, check if it is rotated. If it is, go back, re-rotate. If you see the lens is rotated After a day or two, then probably wait 1 week to 10 days before you go back, open up the bag with viscoelastic and rotate it, because you want the bag to shrink and become a little smaller and more sticky so that the rotation will not recur again. So in summing up, toric multifocals and toric trifocals are quite easy to incorporate into practice, and they are going to be necessary because we're all shifting towards multifocals and trifocals, and we need to address the pre-existing corneal astigmatism to get the best optical results. Thank you. Any questions? No questions? Thank you.
Sir, we have a doubt here.
Yeah.
So have you combined trifocals with monofocals, mix and match?
It's not on purpose. If I'm doing any combination, it is a lens, a thickness lens, 2.75 in one eye and 4 in the other,
Okay.
so that you can get the pseudo-trifocal effect. That I do. I don't do a monofocal in one eye and a trifocal in the other. I do have patients who have got monofocal in one eye already, and they ask for multifocality, put a trifocal in the other eye. And if the patient is happy with one eye monofocal, one eye trifocal, leave him alone. If they request the other eye be done into a multifocal, then I put in a piggyback lens.
Okay.
Trifocal that's available from IOCare, I put a piggyback lens in the sulcus.
And one more thing, for which diopter of astigmatism and above, will you choose a toric trifocal over a normal trifocal? Like combining, to which astigmatic range do you combine LRI, and which astigmatic range you choose a toric lens?
It's a gray area. Any astigmatism at 0.75 I'll do LRI. 0.75 to 1.25 is a gray area, LRI or toric. Anything above 1.25 toric.
Okay.
Hello.
Thank you.
Thank you, sir.
Hello. Hello. Sir, in your view, sir, in your view, which is a good Indian multifocal lens which gives more predictable result?
You mean multifocal or trifocal?
Multifocal.
Truly, no, I believe that every multifocal works. The failure of a multifocal is not on the lens design. It is to do more with the error done by the surgeon in calculation, not surgical mistake. If you're off in your calculation, you have 0.5 or 1 refractive error post-operatively, you have a very unhappy patient. I use every single multifocal in the Indian market, from multifocals that cost available for 8,000 rupees in the Indian market, right up to the imported one that cost 35,000 plus, and I find they all work equally well. There's a gross difference between the photic phenomena and the visual satisfaction between a so-called bifocal, not the multifocal, and a trifocal. That is gross. But if you look at just a bifocal lens, a diffractive lens, I sincerely believe there's no difference whether it's Indian or imported. They're all the same. You need to choose the lens accurately. The dioptric power should be perfect. So you need to apply those techniques to get the best results. Thank you.
Thank you, sir.
Good afternoon and a warm welcome to one and all. At the outset, I would like to thank all the delegates for being here on the last day of the last session, and thank you for being here. And as all of us know, the technology of multifocal IOLs has been evolving. We started with refractive, then we moved on to diffractive lenses, and we also have the a trifocal or the quadrifocal lens from the Panoptics. So what one should understand is that the multifocal technology is still evolving and evolving, and there's one more technology which is in the market, which is called the EDOF, or the extended depth of focus IOL. When this IOL came to the market a couple of years back, so I had my own doubts why another IOL technology when all the other technologies were already been there, and these lenses still give a good range of vision for most of our patients. But I always tell my colleagues, as the old saying goes, know your patient and treat the patient rather than the disease. Similarly, know your IOL before you know your patients, and that is the best way or the mantra to get success with a multifocal IOL. You really have to understand the IOL, as my previous speakers have told you, understand the technology and select the patient. So with this backdrop, I'll go to my topic. I don't have no financial interest with these lenses. and a small guide on what a multifocal lens does. With a multifocal lens is actually a misnomer. It's a bifocal lens. It has two focal points. One focal point is at focus. The other focal point is not at focus, which causes a glare. The EDOF lens, speaking in pure terms of physics, it has the incident rays of light are diffracted by successive rings by a technology called phase-coded technology, which causes a constructive interference to produce elongated focus. This is something which is very difficult to understand. So put it in simple terms, there are multiple diffractive rings. The light rays are diffracted. They are not made to focus, but they are made to elongate the focus. This is what's simple. So because of the elongation of focus gives you the benefit of these lenses. So what a multifocal lens does, the diffractive ray gratings are on the anterior surface. All the light is distributed to the distance. The patient gets a single focal point, no glare and halos. In a bifocal, there are two focal points, one for distance and one for near. And this near focal point is actually made to focus around 1 to 2 millimeters in front of the macula. So when this and the amount of light that is distributed varies for the near and distance depending on the lighting conditions. So because there's two focal points, you have a glare and halos. You need to understand this to understand the EDOF IOL. So in the EDOF IOL, these gratings are put in the posterior surface, and the profile of the gratings are made in such a way that the light rays are not focused at any particular point, but rather it is elongated to give an elongated depth of focus. So how this is advantageous, I'll be talking on it in my next few slides. So this is an animation which shows you how this elongation of focus happens. And when you add on an aspherical and a chromatic aberration correcting technology to this, it gives you a better range and contrast and vision. And as see, all of us know the best IOL to correct your chromatic aberration is your normal single-piece PMMA lens, which has the highest Abbe number. Among the hydrophobic lenses, the EDOF lenses also have the one of the highest Abbe numbers, which reduces your chromatic aberrations. As all of us know, the chromatic aberration accounts for around 2 diopters of depth and focus. So once you correct this chromatic aberration, simply you are able to get another 2 diopters of extra focus, which would be advantageous to your patients. The one thing which you need to understand is the defocus curve. See, normally when you make your patient ametropic, or if you have succeeded in making your patient ametropic, which doesn't happen most of the time, and you put them on the Snellen's chart, and you put in a 0.5 diopter or 1 diopter lens in the trial frame, you'll find the patient vision dropping. But this doesn't happen so when you put in a extended depth of focus IOLs. So this says that the EDOF lenses are more accommodative to the post-operative refractive errors which sometimes happen out of our knowledge. So this is one of the special features of the EDOF lens. So even if you're off your target in the prediction error by a couple of diopters, it is less forgiving on the patient and as the surgeons too. The other important feature is that all of us know about the Strum's conoid, as I had shown in the figure. The elongation of focus covers the extensive Strum's conoid, and hence even if you have a few post-operative refractive error in the astigmatic part, it also covers this too. And as I told you, as most of our previous speakers have spoken, the centration of the lens is very, very crucial. So even if the lens is decentered by, say, 0.75 to 1 millimeters, the patients actually do not complain because of the elongation of focus. So these are the advantages of the EDOF lens. You can get away with decentration, you can get away with residual astigmatism, and with residual refractive errors also. So this is the basis. So now we know about the lens. So no one will be convinced if we don't have data about how these lens performs in our patients. So this is a single center study where we did a consecutive 106 eyes. This is a photograph of an EDOF lens which is taken from inside the patient's eye. So this is one of the Indian EDOF. To describe this lens has come with the technology of being a refractive and a diffractive IOL. So it has got both these components in it with an addition of EDOF category. The central 1.67 millimeter consists of the 3.3 ad and has got a diffractive component into it. And the remaining part of the lens has multiple diffractive gratings. So to summarize, this particular lens is a refractive, diffractive EDOF lens. So we went ahead and did an analysis at 1 month. It was all a retrospective study. We found that around 90 percent of our patients had good visual acuity of 6.6 to 6/9. There was a small group of patients which had some refractive error which accounted for the vision of 6/12. The spherical error, as you could see, we had a very excellent spherical error. Only around 2% of our patients had around 1 diopter which is present, but fortunately we didn't have anything fall under the hyperopic category, so we were able to get ahead with the myopic refraction. The cylindrical errors was also similar. We did have a significant cylindrical error of around 15% in 0.75 and about, but as I told you before, these lenses were less forgiving, and hence we were able to get away with these patients even in the presence of a significant cylindrical errors. The near vision was also good. So finally, the take-home message, how to arrive success with these lenses is that you have to choose your patients well. Select your patients who do not want very good vision from 40 centimeters and near, as Dr. Aravind had put it across. So select these patients well. Do not go for any patients who had a lot of comorbidities with them, or the post-LASIK patients and the traumatic patients also. And the most accurate one is select your biometry. If you could get hold of an optical biometer, it is good, but otherwise you can use the immersion scan. But what you need to keep in mind is that an immersion biometry is around 10 times less accurate than an optical biometer, and the ultrasound biometer is 100 times less accurate than an optical biometer. And so use the latest 4th generation formulas, and any axial length within 22 to 24 millimeters of axial length. Use your normal Barrett's 2, which takes the effective lens position into consideration. Anything beyond 24, use your SRKT, which is still good, and anything less than 22, use your Hoffer's Q, because Barrett's doesn't seem to be more accurate in the eyes or the extremes of thing. And then, as Dr. Minumathan has enlightened, select the patients, very simple surgical techniques, try to do all these cases under the topical anesthesia. But as Dr. Aravind said, it gives the O factor to these patients. Try to get it well-centered, as all of us are good surgeons now, so the biometry is the most crucial factor, and a well-centered lens. So this is what I told about optical biometry, but sometimes when the ocular media is very hazy, these optical biometers do not work well, so in that case you have to go ahead with your immersion microscopes. And what I would advise all the people who are going to start a multifocal IOL, just because some company comes and tells you you put in an IOL, do not do it. At least suppose if you're putting in a Technis IOL, you should have done at least 20 to 30 cases of the monofocal counterpart, refined your surgical induced astigmatism, refined your prediction errors, and then you go ahead with a multifocal. Don't just start multifocal from the beginning of your practice, because refining your prediction error is very important. Modify the A constant also depending on the different lenses. Go to the ULIP calculator where you find the different amounts of A constant which are present, and then go ahead with your multifocals. The latest formula, which is the RBFL formula, which is actually a very excellent tool. It works like how a biometry works for an attendance system. The more amount of data you feed into the system, the more accurate the RBFL fills. It could take another couple of years for this formula to be used worldwide. And finally, my acknowledgements. Thank you. We have another 10 minutes left, and if you have any questions on the multifocal IOLs, we'll be glad to take them.
Dr. Kumaran, very nice talk. Yes, okay.
Yes, the angle kappa is very important because there's a difference between the optical axis and the visual axis. So when you have a large angle kappa of more than 0.5 millimeters, it's best to avoid these patients for multifocal because the central ring is decentered. You have the latest optical biometers which are measured it, and now Aurolab has come up with a small device which is attached to the slit lamp where you can measure the angle kappa. So in general, people with large angle kappa do not go in for a multifocal. And if they really need one, you can try the EDOF lenses with them.
And one more point here is this angle kappa issues is more common especially in hyperopes. When you are treating hyperopes with multifocal lenses, angle kappa issue might become an issue. This happens even in LASIK patients. When we are treating LASIK, because there is difference between visual axis and pupillary center, we might have a little decentered treatment. So the same thing works out here in IOL implantation, that is more commonly for hyperopes.
Hello. Can we measure angle alpha with synaptophore or a placebo-based topography machine?
You can do the Synoptophore also. The Lenstar has it, the Zeiss
Because
IOL
everybody
Master has it.
cannot have a 700 IOL master.
No, if you want to measure it, a Synoptophore can do it. But as I told you, there's a small device which Aurolab has now come with, which is very, very less expensive. We can add on to your slit lamp, and it can be measured.
Excellent presentations. For toric multifocal, how important is it to have the posterior keratometry readings?
Yeah, Dr. Arul, to take this question, please.
It's not just for the toric multifocals, because the newer formulae are all tuned to true K. So getting the true K was an issue because you need to have instruments that measure the true K. Were not available so far. So now some of the swept source OCT-based optical biometers can measure true K. Again, we come back to IOL Master 700. Has got a true K formula. I think they're slowly updating it. They've sold about 45 machines in India so far. I think about 7 or 8 machines have upgraded to true K. You can switch on the true K and you get the true K value. So you get that extra accuracy. But is it really worthwhile and is it very critical? Difficult to answer. Number of people who have a very skewed posterior cornea is small. So, but you avoid that surprise that you get in a small number of patients, maybe 1 out of 200 will be avoided by going with true K. But it's not only the true K for avoiding astigmatic errors. True K is going to give you more accuracy for calculation of even spherical equivalent. So everything put together, yes, if you can get true K and then you have the latest formulae, then you're on the dot. But getting there is pretty much expensive now, but I don't think it's going to be that way for very long. The rate that things are changing, we talk about a matter of days and weeks before things change. So probably in a matter of a year or two, it's going to become very inexpensive.
Also, while selecting the power of the toric lens, the amount of astigmatism, do we also factor in a possible change in the future astigmatism of the patient? Like it is said that there might be some change in the astigmatism. Do we factor in that or we just correct the present situation?
Yeah, no. Just to add on to what Sir said on the toricity aspect of the cornea, he rightly quoted it. So what we have to remember is that the anterior cornea is with the rule astigmatism and changes with age. And the posterior cornea is against the rule and pretty much remains stable throughout life. That is the general dictum when we've looked at large population-based studies. So when you're looking at large quantums of astigmatism correction, you're looking at irregular corneas, as Sir rightly pointed out, the quantum of those patients might be lesser. But you might remember that these are the particular patients who are probably wanting premium IOLs. So when you are looking into premium IOL practice, and when you analyze your keratometries, your preoperative keratometries, and when you're looking at whether it's with the rule or against the rule, that much refractive surprise you might get depending upon the type of astigmatism the patient has had pre-op. So that is the significance of looking at the posterior corneal astigmatism when you're looking at toric multifocals. And I think you'll take on the second question.
One small tip for practical things. One thing is if you are correcting the toric lens, even monofocal or multifocal, please look at the previous refraction. If somebody is having only one diopter of against the rule astigmatism in the glasses, and your topography or the keratometry values which you are having is showing 2.25, you have to be little bit careful in analyzing and treating those patients. The reason being is if you think there is 2 diopters based on keratometry, some of the time we end up correcting more. Those may be those patients who have a skewed posterior astigmatism as well. And another important thing is I have a tool on OptoView which gives both anterior and posterior curvature, so the true K value. But some post-refractive calculation, when you have done the calculation, whether the true K really holds true is also a point of contention, because I have seen when I have gone with topography central K value and it has given me better IOL power calculation and end results than if I had gone with true K value given by the OCT. That OCT can give both anterior and posterior curvature. So using the posterior curvature, we have to be very careful, because true K, whether it is true K, is a point of contention.
We'll take your thing first. True K is true K, there's no doubt about that. You need to put the true K into a calculating software that accepts true K and it's tuned for that. So if you have the Barrett suite and you're using the Hagues L or something, then the true K comes in. Putting true K into a software that is not tuned for true K, then you're going to have disaster. So this goes on opening a Pandora's box. Coming to your, what do you do and how do you predict? Simple, we go with Bayer's nomogram. I still don't remember what is with the rule and against the rule. I'm always convinced. We take it very, very simple. You finally decide how the IOL is going to go. If the toric IOL is being placed vertically or near vertical axis, undercorrect by 0.5. If the toric IOL is going to be placed in the horizontal or near horizontal axis, overcorrect by 0.5. Simple as that. Particularly if it's a young patient. At a 70-year-old patient, it doesn't matter at all.
If any of our multifocal patient is complaining of glare and halos after 6 months post-surgical, how will you deal with them?
You didn't find out what the cause of glare and halos are. Is it because of posterior capsular opacification or epiretinal membrane and all those things? I treat them accordingly. The patient usually doesn't complain of glare and halos after 6 months. If it could happen in the immediate post-operative period or 5 months. So find out the cause of the glare and halos and treat them accordingly. You want to add on this?
Yeah, that is true. And another thing is glare and halos. Some of the dry eye and other surface factors can also play a role in giving glare and halos later on also. Some people developing dry eye or meibomian disease, they can have some loss of visual function, but most commonly after 6 months it is to do with posterior capsule opacification. And many of the time if they are developing, it is better to do a air cap also. Even you see only 1 or 2 pearls, not very much. In multifocals, you have to be a little bit liberal in doing the air capsulotomies.
So
and
do an
do a
early
little bit larger
air
air capsulotomies also.
So there are no more questions. We'll call it a day. And thank you for all of us.
Sir,